Good evening to everyone. Thanks to joining us this evening. For the next 90 minutes, we will discuss about keratoconjunctivitis. Thank you to Medivisi Angelini to sponsorize the event, and thank you to Elos Esaso to host us. The speakers will be David Lockington from UK, Glasgow, Carlos Rocha de Lossada from Spain, and Rita Mencucci from Italy. David will tell us about the importance of a sterilization phase in different kinds of keratoconjunctivitis. Carlos will tell more how we apply the outcome of HEDS study, and Rita Mencucci is focused on adenoviral keratoconjunctivitis, what to do and when to do. After those presentations, we will discuss about some specific case. So enjoy, and we leave the floor to David Lockington, and we'll see you later.
Hi, my name is David Lockington, and I'm a consultant ophthalmologist in Glasgow, Scotland. Today I'm going to talk to you about the ABCs of infectious conjunctivitis. I'd like to thank Esaso, Medivisi, and Angelini for this opportunity, and also Vito Romano for the invitation. Conjunctivitis.com, that's a site for sore eyes, is a joke, and often ophthalmologists feel conjunctivitis is a joke because it's not that important. Today I want to show you what's trivial and what is severe. At the most basic level, conjunctivitis is an inflamed conjunctiva, or often commonly referred to as pink eye. The basic NHS advice suggests that you could just treat the lining of your eye yourself, and here are their recommendations: cool, clean cotton wool, and then possibly antibiotics if required. They acknowledge that you need to limit spread by strict hygiene and not sharing towels, and also say maybe you could speak to your pharmacist because conjunctivitis isn't really that important. Hopefully this talk will refute those claims as we go through the ABC of conjunctivitis, but not forgetting D, which means don't know, and E, which is emergency. This picture shows the problem. There are 3 pictures of follicular conjunctivitis, but which one's herpetic, which one's adenoviral, and which one's chlamydial? And so we need to have a system to exclude rarer and more complex diseases, of which an inflamed conjunctiva is just a small part. So we want to do the basics well. We want to take an appropriate history and a focused examination. Conjunctivitis often is watery with a red eye, the vision is normal, and the discharge can encourage us to point a particular direction, adenoviral being watery, bacterial being sticky, and chlamydial possibly being stringy. However, before we decide this is conjunctivitis, we need to step away from our slit lamp and ask, is this a sick patient? And then look at the face and ask, is this an eye problem, or actually is it predominantly a skin problem, like this picture of severe zoster? Often the patient can give us some pointers that it's the front of the eye which is the problem, with gritty foreign body sensation, and their symptoms can often improve with the use of anesthetic drops. So having said that background, let's look at adenoviral conjunctivitis, A. There have been more than 100 serologically distinct types identified, including 49 which infect humans, and epidemics can happen, particularly with serotypes 8, 19 and 37. The classical symptoms are a red watery eye, preceded with a sore throat, and a patient can often feel a lump in front of their ear, their preauricular lymph node. Adenoviral conjunctivitis is extremely contagious, and there are case reports and case series published showing outbreaks in ophthalmology clinics. And I find that it's interesting that their conclusion to address this outbreak was to remove multi-dose medications, enhance infection control measures, and actually adhere to what we should be doing all along: strict hand hygiene and regular equipment cleaning. I think it's quite difficult to tell the difference between adenoviral and bacterial conjunctivitis. People say maybe the eye's not stuck shut on weight gaining. They say the discharge is watery rather than sticky, and often it starts in one eye and moves to the other. The most common differential diagnosis would be iritis for a red, sore and photophobic eye, which is watery, but you shouldn't see any anterior chamber activity, and the cornea is likely to be involved in adenovirus, but not in iritis. The little corneal spots are often referred to as nummular keratitis. They start on the surface and can stain with fluorescein, but they then become subepithelial and result in negative staining where the fluorescein pools around the swollen area. These subepithelial infiltrates can cause irritation, photophobia, and can be present from about 10 days. Their other symptoms cause glare and haze, including a reduction in visual acuity, and they can last for a good few months and prolonged in some cases. Don't forget that acute hemorrhagic conjunctivitis can also be seen in epidemics, often linked to enterovirus and Coxsackie virus. So how do we treat adenoviral conjunctivitis? Often it's confirmed on a rapid access adenoplus test or PCR testing, though in a number of cases people just assume the diagnosis. Because it's generally mild, it's supportive measurements with lubrication and cool compresses. There's always a debate whether steroid has a role, because it may settle inflammation, but it may cause the virus to persist. And if only we had a solution which was virucidal and anti-inflammatory, and some units have reported the use of an iodine and steroid combination, and I'm presuming we're going to hear a lot more of that later. This recent publication summarizes the main management of viral conjunctivitis, from protective measures, the role of a virucidal such as iodine, and how to address this inflammatory subepithelial infiltrates. There's always a huge debate what is a pseudomembrane and what is a true membrane. Pseudomembranes are fibrin-rich exudate lacking blood or lymphatics, and if you remove them it won't bleed, whereas a true membrane will bleed. However, if you've peeled it off, the test is too late if it started to bleed, because you've created more trauma, you'll cause scarring and you'll cause adhesions. And that reminds us that we need to treat the inflammation and then the membranes will go away. And it's important to do that because down the line there are many causes of scarring conjunctivitis, and we can't assume that, and we need to document what we're seeing, which will help future ophthalmologists make correct decisions in such patients. Just a quick word about in-office point of care testing. There is the RPS adeno detector and now the Adeno Plus, which will give you a result in 10 minutes through the sampling of the tears. It is highly specific, but not as sensitive as you would like. And I suppose the question comes, is this going to help in the normal cases, or actually are these tests reserved for the more diagnostic dilemmas? That leads us on to our second subject, B, bacterial conjunctivitis. And you may feel that the symptoms are very similar. A red watery eye which is sticky in the morning, and the cornea is clear. It may or may not be contagious. In the UK, such patients are traditionally treated with chloramphenicol drops, short, sweet course, and you'd expect some improvement within a few days. Chloramphenicol is broad spectrum, it's bacteriostatic, and it's cheap. Contrast that with the expensive fusidic acid. Of course, chloramphenicol is not used in the States due to historical concerns regarding bone marrow toxicity. We now also have topical azithromycin in the form of Vasotor, which is just twice a day for 3 days. It is extremely effective against the majority of microorganisms encountered. But the question remains, why bother treating simple bacterial conjunctivitis if it's self-limiting and often an allergic reaction to the antibiotic is worse than the original infection? This is a good time to mention ocular MRSA, which is an ongoing battle in the healthcare system. Recent reports have suggested there are no new antibiotics in the pipeline. We have already mentioned that chloramphenicol is not used elsewhere due to vague fears about aplastic anemia, though the population studies do not indicate causation. And it's interesting that it's highly effective against MRSA ocular surface infection. Despite those worldwide concerns, it's readily available over the counter in the UK. You can self-prescribe it. And clearly we do not have hospitals, towns and cities full of people with aplastic anemia. So a few years ago we wanted to review our ocular MRSA antibiotic susceptibilities, see what management we were offering and see how effective the treatments were. We performed a retrospective review of 100 consecutive MRSA positive ocular swabs. There was equivalent male-female ratio and the mean age was 62. 2/3 came from hospital and 1/3 came from GP land. The vast majority of patients were swabbed because they had Blepharoconjunctivitis. All the cases were susceptible to vancomycin and only one case was resistant to chloramphenicol. Reviewing the case notes highlighted variable and inconsistent management, both in terms of drops or ointment and frequency and duration of treatment. It was also noteworthy that only a quarter completed a 5-day systemic decolonisation program with chlorhexidine. Of those retested, 10% remained MRSA positive, but it was felt based on their treatment and management regime they had been inadequately treated and hadn't received appropriate decolonisation. So why is this relevant? Well, we had a very high eradication rate with chloramphenicol, and the cost is significantly cheaper to use chloramphenicol rather than vancomycin. There are concerns about vancomycin resistance, and this is often reserved for those sick patients in ICU. So we would suggest using topical chloramphenicol 4 times a day for a week with systemic decolonisation therapy is a cheap, effective and safe first-line therapy for ocular MRSA, and we can reserve vancomycin for the more severe or resistant cases. However, if there are no new antibiotics in the world, there are some antibiotics which haven't been used, and some unexposed population groups could benefit from this. So it'll be interesting to see in the future which of these antibiotics will come back into fashion. And you can read the details of that article in January 2018 in the journal I. C stands for chlamydial conjunctivitis. As I said before, a stringy discharge is not a reliable sign. Equally, I don't think people wear underwear like this, so we have to consider the demographics of our patients and look beyond our assumptions. If you see a patient who has chronic unilateral follicular conjunctivitis for greater than 1 month, that is chlamydia conjunctivitis until proven otherwise. They need swabbed and tested. But who is best placed to provide this service? As we know, systemic treatment will clear the ocular symptoms. In Glasgow, we have been sending patients to the sexual health clinic for further testing and allowing them to initiate treatment as an incentive. Because if we don't eradicate it elsewhere, there's the issues of infertility and reinfection. You also don't know what other sexually transmitted diseases you're missing because you're only swabbing the eye. And so we believe a robust multidisciplinary strategy will address these cases, particularly as often the multiplex assays, such as in Glasgow, contain chlamydia swabbing as part of their routine. I'd like to mention some of the don't know features of conjunctivitis. If you've ruled out the ABCs, you want to retake your history and double check the areas which warrant special attention, as shown in this diagram. You want to consider the patient's psychiatric history. Is this artifact because they're deliberately putting things in their eyes? And often healthcare workers or people in hospital have access to things. I put this picture of a stapler there as I once saw a psychiatric patient who kept putting staples in their upper eyelid, and only by removing this from them did their conjunctivitis resolve. What about their surgical history or their drug history? Is this a surgical conjunctivitis actually a blebitis, which is much more severe? Or have they been using long-term glaucoma drops and now have a red eye? These are the 5 things I think about whenever I think that conjunctivitis is atypical, not the ABCs. Is it molluscum? Look at the lid margin. Is it herpetic? Is it toxic due to deliberate drops or deliberate damage? Is there actually blepharoconjunctivitis due to blepharitis? Or is there conjunctivochalasis? Don't forget the patient's systemic health. Their red eye, which is photophobic, may not be an eye problem at all. They may be septicemic. They may have meningitis. They may have chickenpox or the other conditions listed here. So don't forget, you're still a doctor. Consider their general health and their skin joint problems to see if that can give you any clues as to why they have a mucous membrane which is inflamed. And I just remind you about Blepharoconjunctivitis, where you have inflammation of the eyelid, which can cause localized chronic infection. Beware, it's not herpetic, and often there's a role for PCR testing in these patients, so they're not always branded as it's always blepharitis, or it's their herpetic eye disease coming back, and we'll probably hear more of that later. My final tip would be beware the beard or other hair which blocks your view of the skin, and the eyes will only be as healthy as the skin they're in. And in this patient who had a beard, we missed the herpetic skin lesions which corresponded to their corneal signs. Finally, I'm going to talk about emergency conjunctivitis. It's an emergency if it masks a more sinister diagnosis or is sight-threatening. Be suspicious of florid discharge in gonorrhea conjunctivitis, as the cornea can melt within 48 hours and they need systemic intravenous antibiotics. Sticky eyes in a child is often delayed canalization, but if they're red and sticky, consider Neisseria or chlamydia. They need swabbed and treated. And finally, beware the accuracy of family members giving second-hand histories for children. This is a conjunctivitis, but it's due to sharp trauma from falling onto scissors. This patient had a penetrating eye injury. So in conclusion, remember the ABCs of conjunctivitis. It's not boring and it's not always trivial and transient. Consider the impact of rarer or more complex diseases, and make sure you only use steroids appropriately when you know the diagnosis. Pink eye is not a diagnosis, it's just a sign, and we need to identify what is going on so we can treat them appropriately. And we're going to hear more of that in this session. Thank you for your time and attention.
Thank you very much for this kind invitation. Here my disclosure. I would like to try to touch different topic that I think we can find in our clinical practice. So first of all, I think it is very important to know, or just something about the biology of the corneal herpes infection. We have to know that this virus go inside the eye through the cornea. Normally, they produce a replication in the epithelium and then go through the ciliary nerve. We have to remember it's belong to the first branch of the ophthalmic nerve and go to the trigeminal ganglion. Then here they produce like a latent station, but sometimes in the life we know that some stressful situation they can produce an activation and go again with the same nerve, with the same ciliary nerve to the eye, and can produce different kind of manifestation. Most of them in the cornea, but we have to know that in different parts of the eye, actually. For corneal part specifically, and especially for the resident, we have to remember different manifestation. First of all, and the more frequent is the epithelial defect. We have to remember this kind of bulge, the terminal bulge is very, very characteristic of the herpes keratitis. With this, we can differentiate between this pathology and different microbiome like amoebas or especially herpes zoster. Another manifestation that we can find, especially in people that they are using topical corticosteroids, this ulcer. The name is a geographical ulcer because it resembles to a geographical map. Another manifestation is the endothelial part, where we can find this ring, the Wesley ring. We have to remember that although it's very, very common in herpes, it's not pathognomonic. And actually, this type of manifestation we can also find not in this disciform shape, but we can also find lines or diffuse manifestation. It's very important. Then another is the stromal keratitis. Classical definition, we can difference between with ulcer or not ulcer, or with necrotic signs or non-necrotic signs. But I I really recommend this paper because here they suggest that we have to finish with these historical terms, and we try to follow this new classification because it's very easy for us. We can, yes, we need to look which part of the cornea is affected, and with this we can go in a good or an easier management. Actually, if we find an infection in the epithelium, we only need antiviral drugs. But if we find different part of the eye, of the cornea, we need also a corticosteroid. This is very, very important. Another topic that we can find in our clinical practice is atopic patients. In this research, the authors found that the incidence of Blepharoconjunctivitis is more frequent in this atopic patient. But the inflammatory disease of the herpes, they say inflammatory in stromal and endothelial, is less common in atopic. And in the same group, but in another paper, they found that the antiviral prophylaxis could be a very, very good option for especially for the infected part of the herpes. What is known, this is the semi-herpeticon that we can find in atopic patient, is something controversial. Is bilateral or not? It seems that it's bilateral, but in different research they didn't find it. But we can find these ulcers in the face bilateral, but the eye could be just unilateral. But what this is published that the response for the therapeutic is very poor. It's very difficult to manage this patient. Also, we can find these ulcers in the conjunctiva. It's very, very important, especially in immunosuppressed patients. So we have to look and take care in this patient. In this nice picture, most of them, especially for the resident, we can know which is the diagnosis of this pathology, because the diagnosis is generally clinical in herpes, especially in the epithelial disease. But sometimes this classical picture is not very easy to find, especially because there is some super infection or different kind of manifestation. So what is published recently is maybe we need some another test, especially PCR. So nowadays, PCR, at least in certain cases, could be the gold standard. Regarding management, I think it's very, very important to know that the guidelines are needed, or at least we need to follow guidelines. I think, at least in my humble opinion, we find every day colleagues, myself, etc., residents, we don't know how to manage different herpes patients, because we don't know how to do the management, the diagnosis, etc. And actually, this is published in different papers, that because of the not in all the countries have the same drugs, the same guidelines. Maybe it's a hot topic that we need to work on it. But we know the antivirals, especially the acyclovir, both topical and oral, could be effective in the management of the epithelial disease. It's a very, very important. We can manage our patient both using orals or topical. Also, different drugs has been published, And now we have more drugs, and we have another clinical trials where we can find that valacyclovir is a prodrug called the acyclovir. It could be also useful for these patients. So if we follow the recommendation, the Cochrane recommendation, we can find different antiviral, topical antiviral that could be effective in management of the PTR keratitis. And also, again, the oral acyclovir could be an alternative to topical. But what is published is currently there is no evidence for the combination. This is not a problem, but we see every day for every colleague, every resident, etc. But what about the HEDS? This trial, I think, is a very, very, very important trial that we need to know about them. One of the first, by Baron et al., they found that there was no statistical and clinical beneficial of using oral acyclovir in patients we are currently use corticosteroid and trifluridine. So it seems that we don't need to use both antivirals. In another trial, the same eye, they studied the use of corticosteroids, and they find that patients with stromal keratitis, if they use corticosteroids, they have less progression and persistence of the inflammation and less duration of the disease. So we need to use corticosteroid in stromal keratitis. But remember, in stromal keratitis, we have two different forms, without and with ulceration. We need both antiviral and corticosteroid, but we need to know that without ulceration, we need a prophylactic dose, and with ulceration, we need treatment dose. The same group, they study how the PTR keratitis can recur in patients with a stromal keratitis, and they found that previous PTR keratitis, they have a higher rate of PTR keratitis again. The same group, years later, they also found that also the stromal keratitis are a higher risk for recurrence. Years later, the same group, another HEDS trial, they studied the oral acyclovir for the prevention of the stromal keratitis in patients with PTR keratitis. And they found that at short terms of oral, they have not apparent benefit of when they use the oral acyclovir again. But one of the last HEDS trial, I think, is very, very important, published in the New England Journal of Medicine. They found a patient that they have been used with oral acyclovir. They have a reduce in the incidence of any types of ocular corneal infection. This is very important. Patient, when I think we need to follow this trial, we have to put on acyclovir at least for 1 year. But again, different research, because we have different new drugs. They also found that valacyclovir could be as effective as acyclovir. But sometimes we can find this in our clinic. We find this type of ulcer, but this is not actually an active ulcer. It's a topical antiviral toxicity. So it's no longer an activate disease, but it's a kind of iatrogenic disease. Okay? Not totally, but a kind, maybe. Or this type of ulcer, what the name is metaherpetic keratitis, it's not an activation of the keratitis, but it's a chronic keratitis. It's like a kind of neurotrophic ulcer. because we need to remember that the herpes and actually the tropical drugs could produce this neurotrophic keratitis. So we need to know, because the management is completely different. So when we can use oral or topical for something that could be logical, for example, people that they cannot put by themselves the topical drugs, people with contact lens, pediatric or ocular surface disease, and in topical, people with who are elderly or who have a renal impairment, pregnant, nursing, etc. Regarding the resistance, first of all, I think it's very, very important. We have to confirm there is actually a herpes infection. But if we find a positive result, we have to ask the patient if they are using the drugs in a good way, because we know that especially the acyclovir, and they have to put them many times per day. So sometimes they don't follow us. So maybe it's important to start with this approach, just asking people if they are doing a good way. But again, it's true. Sometimes we can find patients with resistance. So we need to know that it's more frequent in immunosuppressed than in monocompetent people. And we have some alternative. First of all, we need to know that most of them, almost 100%, is because of mutation in the thymidine kinase gene. So we have different drugs, topical or intravenous, like Foscarnet, Cidofovir, and actually in a different case report, they found good outcomes with valganciclovir. But we have new horizons in the management of this herpes keratitis. I don't have any experience with this, but we have to know that the researchers are looking for different new drugs, because we know we have some problems nowadays. What happened with children? We need to know that children have a more frequent recurrence than adult people. Almost 25% could be a bilateral keratitis. And actually, in different research, they have been published that almost 30% of the patients could be misdiagnosed because of this, because the manifestation could be different, it could be bilateral. So we have to think about this disease also in children. Because, again, sometimes could be late or misdiagnosed and could produce an ulcer that then produce a scarf, and then can produce an amblyopia. It's a very, very hot topic, actually. So the management maybe is easier if we use oral acyclovir. Actually, again, because something logical, it's very, very difficult, the management. The children, they cry, they move a lot. It's very difficult to examine. So maybe with oral, we can know, or at least try to know, that they are using the drug in a good way and not in topical. And what is published is that in this patient that they are adhered to the acyclovir prophylaxis, they have a less recurrence than people with no. Very fast, eye surgery. We don't have guidelines, but in this paper, I think it's a very interesting paper. It's a survey in the United Kingdom. They suggest that cataract surgery should be delayed at least 3 to 6 months before the patient with herpes simple have a no active state. That oral antiviral could be interesting in these people. and there is no need for alteration the postoperative routine of corticosteroid regime. But again, we don't have any guidelines in this type of surgery. The same in the refractive surgery. At least it seems that we can operate these people, but not people we have a lot of recurrence of the disease, and we need at least 1 year with no disease with activate. And again, we need to have to put this patient with a prophylaxis. But again, we don't have any trials that they studied this how to manage this patient. Regarding a corneal graft, the same. It could be interesting if we put in a prophylaxis way to this patient, but again, we don't know how many time and how drug is the best option. But it seems that we need to put what we don't know exactly. And regarding pregnancy, it seems that topical maybe might be preferred because the topical is very, very difficult to pass to inside the body. But we have to know that acyclovir, valacyclovir, and acyclovir are B category. And in a large cohort, I think this is a very interesting study. They found no association of the in a major birth defect in women that they use this drug. And in lactancy, we have to know that acyclovir is authorized. And actually, this man that they are using the drug, they don't have in their milk. These are a little amount of the drug. I would like to show some recommendation for you. Take home message. I think we have a lack of guidelines, or at least we don't follow guidelines. Maybe we can create new for different countries. I don't know. But I think we need to follow the trial that have been published. Maybe we need to create new ones. And remember this paper that maybe it's an easy way to classify a management patient with herpes keratitis between the layer and the drug. Thank you very much.
I would like to thank Professor Vito Romano and the ESASO board for this kind invitation. At first glance, adenovirus may appear an obvious topic, but as you'll see, something is not completely clear and the management has still to be defined. Everybody knows that conjunctivitis is responsible for a large number of office visits in Europe and the USA, with an annual cost up to $900 million per year. Adenovirus is the most common cause of infection of the ocular surface, with more than 75% of conjunctivitis cases and a low diagnostic accuracy of less than 50%. In fact, although over 60 years have passed since the first causative agent was identified, our understanding of this disorder remains limited. We know that this is only an overview in very, very basic virology. We know that the virus is a non-enveloped one. That means without an outer lipid layer that makes this infection a tough problem. It's an icosahedral capsid with the double-stranded DNA classified into 7 species from A to G and more than 60 serotypes. Several serotypes of species B, D, and E have been associated with ocular manifestation. It has a very efficient intracellular entry through endocytosis, with the release of viral DNA genome into the host nucleus, the virus uses host transcription machinery and replicates with the production of viral proteins that cause cell lysis and release of virus. We have to keep in mind that the virus causes a lytic infection of mucoepithelial cells of conjunctiva and cornea. Adenovirus can cause not only keratoconjunctivitis, but also respiratory infection and gastroenteritis, as you can see from this table. The virus can survive on object for weeks, and it is highly contagious, and this is particularly dangerous for we ophthalmologists. An important pitfall is its long incubation period, from 5 to 12 days. Infected individuals can shed virus particles for up to 2 weeks after the onset of symptoms, and the virus may persist on dry surface for weeks. We can have several ocular infections spanning from not severe form of non-specific follicular conjunctivitis and pharyngoconjunctival fever to a more severe form such as epidemic keratoconjunctivitis. Today, our attention will be focused on EKC, mainly associated with species D, serotypes 8, 19, and 37. The clinical feature may range from a subclinical form to a more severe ocular form where the cornea is involved. Often bilateral, generally starts in one eye and the second eye usually is involved 2 to 7 days later. The symptoms and signs are the classical of conjunctivitis, but in severe cases, we can observe conjunctival pseudomembranes, scarring, and symblepharon. Let's focus on corneal findings. In the first week, we can observe mild multifocal punctate keratitis, usually to the replication of the virus in the corneal epithelium. 2 weeks after the onset of ocular symptoms, focal subepithelial anterior stroma really infiltrates, the so-called SEIs, appear in 20–50% of cases. Only rarely we can observe mild, large central geographic corneal erosion. Surely, SEIs are the hallmark of EKC, may last for many months or even years after the initial infection, are generally small, up to 1 millimeter in diameter, oval to round, most typically number 10 to 50 or even hundreds in severe cases, of course causing photophobia and reduced visual acuity. The histopathological hallmark is an accumulation of lymphocytes, macrophages, monocytes, and activated fibroblasts in response to infected corneal keratocytes, as we can observe also from confocal microscopy, in which we can see very clearly activated keratocytes. This is one of the latest hypotheses. In a 3D corneal facsimile simulation, viral activated keratocytes can attract blood leukocytes that migrate against gravity through the matrix to form sub-basement membrane foci. The diagnosis is mainly clinical. Cell culture, PCR, whole genomic sequencing are generally not used in the routine. In recent years, RPS, Rapid Pathogen Screening Adenodetector, has been used with a good specificity and less sensitivity. Adenoviral conjunctivitis is a significant global economic burden due to the highly contagious nature, the long incubation period, the lack of gold standard for testing and treating. In fact, there is no FDA-approved antiviral treatment from adenovirus infection, and current management is only palliative. This is a summarized scheme of clinical management. The first step, of course, is adopting a protective measure with virucidal disinfection, hygienic measure, and isolation of patients. But let's review briefly the other points. Several antiviral drugs have been taken into consideration, but due to their toxicity and possible drug resistance, only topical ganciclovir is currently used, with some results reported in literature, but not a full consensus. The classic mainstay of therapy is represented by steroids, widely used in clinical practice, both in short-term acute phase to improve EKC symptoms, but also in chronic use to prevent and to treat SEIs. Their use, however, is controversial because the treatment of SEI can result in a high recurrence rate because it is difficult drug tapering, and because if discontinued suddenly, viral antigen continue to attract lymphocytes, causing persistence of the infiltrates, with a delay in viral clearance with prolonged viral shedding. Is there some space for non-steroidal anti-inflammatory drug? Certainly, they do not increase adenovirus replication or extend infection duration. They can help in reducing photophobia during acute phase. They are useful for pain relief and for the prevention of the inflammation rebound when tapering steroids. However, their use is controversial because they have not significant antiviral effects and no effect on corneal infiltrates. And there is also a remote risk of corneal melting. Immunoglobulin-based therapy is not used in clinical practice, even though a certain antiviral activity has been demonstrated, both in vitro and animal in vivo, in the early phases of infection. Anyway, human data are lacking. Much more used is immunotherapy, mainly topical cyclosporin, that has been used in the acute phase to decrease the risk of developing corneal findings, and chronic phase for persisting SEIs more than 3 months. Topical tacrolimus is much less used. Surgical management, usually it is not required, but for patients with chronic infiltrates, a PTK with low dose of mitomycin C can be an alternative option to the other corneal surgeries or transplant. But can we change the rules, avoiding all this? Povidone-iodine is an old friend of ophthalmologists, and its use represents the gold standard in preventing endophthalmitis. Definitely less known is its role in managing adenoviral keratoconjunctivitis, and PVPI irrigation is still an off-label procedure. Starting from the so-called paradox effect of PVPI, for which a low concentration can assure a good antimicrobic antiseptic action, a possible use of diluted PVPI has been proposed. And these are some reports published on this approach using PVPI alone or in combination with steroids. Following this track, this is the latest paper by our Italian group in this perspective. Randomized multicenter controlled study in which 59 patients were divided in two groups. A group, 34 patients, treated with povidone-iodine 0.6% 4 times a day for 20 days. And group B, 25 patients, treated only with the hyaluronate-based TR substitute 4 times a day for 20 days. The outcomes were resolution time of the infection in terms of SEI decrease or resolution, conjunctival chemosis and injection resolution, corneal transparency recovery, subjective improvement of symptoms, changes in best corrected visual acuity, corneal densitometry, corneal staining, pachymetry. And here are our results. Corneal pachymetry, densitometry, and best corrected visual acuity, no statistically significant differences between the two groups. But, most important, the resolution of acute adenoviral infection was faster in PVPI 0.6% group than TS substitutes. And, very important, the incidence of SEI development was statistically reduced after 20 days in A group, the group treated with povidone-iodine. As you can see from this table regarding the number of patients with SEIs in the two groups at different times, we can observe a statistically significant fewer patients in the group treated with PVI. Again, other results. No corneal A's in 100% of patients of the A group at the end of the study, no side effects from the use of PVPI eye drops, and objective signs and subjective symptoms reduce in PVPI 0.6% group, as you can see from the diagram. So in conclusions, the use of PVPI 0.6% in the first few days of clinically significant EKC can help to reduce the risk of SEIs. Diluted povidone-iodine ought to be started as soon as possible when we suspect EKC. It decreases the incidence of subepithelial infiltrates, presumably by reducing the viral load. And so, povidone-iodine could be a useful, cheap, safe, and easy to access aid in the management of EKC in common clinical practice. So, the rules can be changed. Of course, finding new treatments to target the genes implicated in adenoviral replication will be one of the key aspects to curb the worldwide socio-economic burden of EKC disease. But currently, low-dose povidone-iodine use to reduce the incidence and the severity of subepithelial infiltrates may be a considerable step forward to manage epidemic keratoconjunctivitis. Thank you.
Again, and thanks for coming to listen all our 3 talks. Thanks again to the speaker for these amazing talks. I'm going to remind you one thing. If you want to do any question or you want to raise any point in the discussion, please write in the chat box that will be on your screen in LSTV or on Workplace. As soon as you will write the question, I will then pass to the speakers. So I will want to just thank you again to David Lockington, Carlos Rocha de Lossada, and Rita Mencucci for their amazing talk. Welcome again. And now, if you are happy, I will pass you some questions. Are you okay? So let's start. David, thanks again to share, first of all, the finding of your papers and what you highlight in your papers. That one was just published on last summer on BMJ Open Ophthalmology about the importance of the sterilization phase and how to use this povidone-iodine on the ocular surface. My question is, how do you use in the practical in your clinic? When do you use it in the beginning of the infection, on any infection, to reduce the load of the microbacterial?
Yeah, thanks. That's a great question, and it opens up so many more questions, because if we think about it, the ocular surface should be clean, because the lids and the conjunctiva should have an active role in keeping the cornea protected. And when that breaks down, there is the potential for bugs of any type to get in. And so we know that povidone-iodine is extremely effective as a bactericidal in that it kills bacteria, but we also need to remember it's virucidal. It kills virus. And for that reason, and basically it kills everything. So that's why we use it in pre-op cleaning. That was a huge change in our history, from using silver-based solutions to iodine-based solutions. And we use it every single day in theatre. But we forgot about it in the clinic. And so in answer to your question, we are limited by what products are licensed for use in the eye and what our culture traditionally lets us do. So we know antibiotics are good for bacteria. We're not really sure what antivirals are active against other than herpetic. And then we have the antifungals and the other things. So increasingly, if we saw a particularly inflamed, infected eye, and we know that the first treatment of an infection is sterilization, then iodine, if it was licensed and available, has a possibly unique role. You could see a patient, you could take your samples and your scrapes and your swabs, and then you could probably sterilize the surface more effectively with an iodine preparation as a general treatment. And then when you get your positive results back, you could target that treatment with relevant antibacterial, antiviral, as Rita explained brilliantly.
Exactly. This, I think, is the point. I think, in particular in ophthalmology, when we start a treatment, the first 2 days probably it's empirical treatment. It's based on what we normally or we think it is, or normally what we the kind of infection that we have in that kind of region. But if we add to this thing something that sterilizes, reduce for sure the viral or the bacterial load of the eye, and will help a lot. In addition, I don't know if you, Rita, do you agree? Because the advantage of this kind of povidone-iodine is not create that resistance that the other bacteria, the other antibiotic can have it, or antiviral can have it. I know, Rita, that you use these licensed drugs that it's called povidone-iodine 0.6% in your study. And do you find, so the reason why, first of all, my question to you was, do you find that the patient has a little bit discomfort or they have any allergic reaction? And second thing, which is the mechanism that doesn't create the resistance for this kind of drops?
Yes, so a lot of questions. First of all, the main mechanism in which povidone-iodine acts on a virus is targeting on the cell wall. And this is very, very important because it mainly oxidates the cell wall. And so the mechanism is not directed towards the DNA, for example. And this could be a reason why residences are not known using povidone-iodine, first of all. Second, you know that as you have just heard, there is not a current FDA approved or guidelines in treating adenoviral conjunctivitis. So it is very important to find something that can permit to let us to have less infiltrates. We know the infiltrates are the real problem of this kind of keratoconjunctivitis because they can last weeks and weeks and months and even years. So to have something that, at least in our study, can prevent the formation of the infiltrates is a very, very important and really a step forward in treating these difficult cases.
Thank you very much. I'm raising a question from the chat box from the audience. They're asking, is your treatment in this kind of on keratoconjunctivitis different according to the age? So if there is a difference for treatment, a young pediatric patient and an adult patient?
There is very, very, very few reports about the use of povidone-iodine in children. Only one study from a Turkish group treating children with povidone-iodine. In our study, the patients are adults, and no difference between different ages. I think that we need more study in treating viral infection, adenoviral infection in children, but we know that generally are less tragic than in adults because generally are pharyngoconjunctivitis fever, and also often we can see other not pleasant things on the cornea.
Thank you so much. There is another, sorry, Carlos, I will, there is a question from you from the chat box, and they're asking about systemic treatment with acyclovir. Is there any difference between therapeutic dose and prophylactic dose? And how I will add for how long there will be the dose. So,
yeah. Okay, so the difference between the therapeutic is 5 times per day, okay, and the prophylactic is 2 times per day. Okay, so then if we remember this paper that they say that it's good to differentiate between the layer of the cornea that is affected in the epithelial and then just the corneal keratitis, is the acyclovir is just for between 7 and 10 days. Okay, and in stromal, if we follow the HEDS trial, we need to continue at least for 10 weeks. Okay.
Are you talking about? Sorry to clarify. Are you talking about acyclovir 400 milligram?
Yes.
Twice per day or 5 times per day. Okay.
Yes.
That's fine. In herpes keratitis, right?
Yes. In herpes simple keratitis. Okay.
Coming back to the question about infiltrate, and do you think that these are the infiltrate and so make the problem for the patient? Are you using a steroid in the first phase, or you use later on? I want to know your experience between David and Rita. Which is the difference in your countries? What's your kind of different?
Vito, thank you very much for the question, because I think it's a basic one. Because even though in literature you can find that the corticosteroids, no please, because they can increase viral load and viral shedding and so on, in practice we know that steroids are used in the acute phase to reduce the symptoms, and are used in the chronic phase to reduce the inflammatory response, to try to tame the infiltrates. But we know that there is a very, very high rate of recurrence using corticosteroid. And another thing that is important is how to taper them. Because if you taper briefly and suddenly the steroids, you can have a rapid recurrence of the infiltrates. So I think that maybe the ideal is an adjunct therapy, that is to use something that can decrease the viral load, that is, for example, iodine in this case, and some steroids just to tame the infiltrates. So be careful with the steroids and don't use them, don't use them for a very long period. I think that just in the beginning maybe, but maybe that the future will be in conjunction with something else, that is your iodine, in my opinion.
That's great. Thank you. David, what's your experience? You think it's the same, and you act the same in your clinic?
Pretty much. What I would say is to expand from what I said earlier. We are traditionally taught that a virus will go away by itself. So we do nothing, maybe a bit of lubrication, and hopefully it'll be fine. But we know from what I said earlier that keratitis is an inflamed cornea, which might be due to infection. So you sterilize the cornea will cause even more inflammation. And so the second step of healing is sterilization and then suppress inflammation. And what Rita has shown beautifully is by suppressing the viral load, you reduce the inflammation. But to address that, using iodine alongside steroids is the perfect combination to settle down the virus and prevent the longer-term infiltrate damage due to inflammation. So whenever I did my fellowship in New Zealand about 9 years ago, they were getting the little minims of iodine and the little minims of dexamethasone and mixing them. And they would use them together 3 times a day for 2 weeks. But often after 1 week, the patient would stop treatment because their symptoms were gone. And I often think, what would I want in my eye if I had adenoviral keratitis? And the answer is, I would not want it to progress to subepithelial infiltrates, which would give me photophobia and could reduce my vision. So if I had adenovirus, I would want treatment rather than hoping my body would clear it. And the treatment of a virus is a virucidal, and the treatment of inflammation is steroid. So for me, I want the iodine and the steroid for the first week or so. And I think that's where the role of these rapid diagnostic tests come in, because if you get a quick diagnosis, you can jump on top of the virus before it gets out of hand. And what Rita described, using steroids without antiviral makes the virus go mad. So knowing what you're treating and treating it sensibly with the products we now have available makes sense. So that's a new concept, even before we get into antibiotic resistance. If you think about it, people often said, here's a viral conjunctivitis, but just in case it's also bacterial, have an antibiotic, which isn't going to do anything. It may lubricate, but it's not going to address the virus. So what we've heard tonight makes perfect sense. We now have a treatment for a condition which is contagious and causes ocular problems.
I completely agree. I think, thank you so much for raising this point. I agree that this one brings something new and something that we can play in a different kind of strategy. And on the same thing that you're saying for your paradigm that you're using sterilization, and then we need to look after the inflammation. This, I will say, probably we could use. It's not nothing published yet, but we could use in association for bacterial infection, because if you are going to reduce the load of any kind of microorganism, I think for sure you will win quicker than before. So probably in one of the next steps, probably that we should look into it, if an association of this kind of sterilization treatment with an antibiotic could help also to achieve a better results and a quicker resolution of this kind of treatment. What do you think?
I'll let Rita answer that, but I think that makes perfect sense. Rita?
Vito, another thing that, in my opinion, should be underlined is, because I think that it can create false ideas of not functioning, is to use iodine when the infiltrates are already present. Because we know that the mechanism, you have heard my presentation, David's presentation, the mechanism of infiltrates is an immunological one. So I think that this is not the target of iodine. So we have to use, as David already said, at the beginning of the disease. And RPS, I agree with him, RPS could be an important tool just to know very, very early if it's a viral infection. So I think we have to change the rule, really.
There is one of Carlos, please.
Yes, I am completely agree. I think we have one big problem in our clinic is the culture, the diagnose tools. So as David said, that it could be possible to start with something that works actually, and have it's very, very low percentage to produce resistance. So I think we may try to do this trial, because it seems that it's theoretically plausibly that the iodine can work in not just in adenoviral or herpes, in all the, actually also in corneal ulcers. So I think it's a very, very good option. I think most of us we use in our clinical practice, but we need to create these trials. That at least is my opinion.
Thanks so much, Carlos. I'm passing you, and probably just to reply all together. There is an Antonio Torre from that raised a question. Say, do you use povidone-iodine in prophylaxis in anterior segment surgery? My question, I don't know. My answer is I normally I don't at the moment, but I can say that I recently read a paper just published probably this week or the week before, where in this paper they use povidone-iodine 0.66% in a patient before cataract surgery and 3 days before, the load, also the microbiome in the eye with the drops and the contralateral eye. So using the other eye as control, and they saw that there is a reduction of this kind, reduction of the load of a microbiome. So this could be probably something that they could do in the future, but at the moment I don't know more than this paper. Regarding instead the same things that could be used also for EBT, so intravitreal treatment, intravitreal injection. So probably you could use instead of antibiotic in this kind of a patient. Other things that other things I don't know if I don't have much more knowledge about this kind of question. Do you, Rita, David, Carlos, do you know more about it?
We don't use for intravitreal injection. My hospital is a big center for retinal diseases, and so we do really a lot of intravitreal injection, but we don't use anymore antibiotics, not before, not even after the treatment. So I think, but we use POVIDONE-IODINE, of course.
Yes, the same.
So I would agree with that. We don't do pre and post antibiotics for intravitreal injections, but they definitely get povidone-iodine, and similarly before every ocular operation. I don't know if you're going to ask this question, Vito, but I'm going to bring it up now anyway, because the literature showed that iodine is superior to chlorhexidine. So the reason I bring that up is because there's this controversy about allergy.
Yes.
And before we get into that, all I would say is, if a patient comes to me and says they have an iodine allergy, I say to them, they already have iodine in their body, so they can't have a true iodine allergy. They can be sensitive to the excipients and other things in the povidone-iodine, and in some circumstances I have put it on the back of their hand to show them that they haven't had an anaphylaxis before the surgery, because I am not prepared to allow them to go blind due to an infection because they didn't let me clean the eyes properly. And you'll probably get into the discussion about shellfish and contrast, and Rita's nodding, so let her speak. But to me, it is a wrong discussion. It is not an anaphylaxis to iodine. Rita, what do you think?
Yes, I thank you, David. Thank you, David, for underlining this myth that is iodine allergy. Really, there is only some discomfort using iodine. It can be more with more concentrated solution. Below 1% it is really rare to have more stinging and burning sensation. There are very, very, very few allergic dermatitis below 0.0% of cases, and really no anaphylactic cases has been described till now. So I think this is very important, Vito, to underline, because there is a myth about allergy and cross-reaction with shellfish and so on. So thank you, David.
I think it's a very good point that you raise, and also we need to also highlight the difference in time. So in terms of the effectiveness of the iodine, povidone-iodine, is between 30 seconds and 2 minutes. The other one is around half an hour. This make understand the effectiveness of the both. So the povidone-iodine versus chlorhexidine. I want to say that to the chat box, Vittorio Picardo is raising a point to say that he used iodine in the pre-op of all his surgery and also in the end of all his surgery, and he said there is no problem. So this means that you can use this kind of drops. That if I'm right to say, Rita, I know that you use it. So this kind of drops, it's between an artificial tears plus povidone-iodine. Yes. So it's a little bit more comfortable than using just povidone-iodine, right?
Yes. Regarding the specific question, I use the povidone-iodine before the cataract surgery, but not after, really, not. Because I use intracameral antibiotics. There is in the guidelines of our hospital and in Italy, really, all over.
But I will say that this one, more than I don't know regarding the surgical, but I found that these drops, this povidone-iodine, that as David said before, we need to bring in clinic, because the clinic is the one that we are missing. So the one that we didn't use so far. But we have this tool that does have resistance, can reduce the viral load, the bacterial load. At the moment, there is some evidence just in vitro that they can have effect also on protozoa or fungi. But I think it's quite good in order to use in clinic and to bring to have look into it and probably give better results later on.
Vito, I don't dispute that, and I hear that you want to talk about the clinic, but I must say, if you look at the ESCRS guidelines for the prevention of endophthalmitis, there are only 3 things you can do. Number 1, control blepharitis beforehand. Number 2, pre-op cleaning with povidone-iodine. And number 3, intracameral cefuroxime. If you've cleaned the lids properly, your ocular surface should be relatively sterile. And I would have concerns that you may do no harm putting iodine on at the end, but if your wounds are not sealed properly, that iodine could get into the anterior chamber, and that would cause me concern. So we maybe feel that we're doing something to help the patient. I'm not sure the literature shows that makes a difference. So I would just be cautious about putting iodine on an eye which has been open for that reason. This is how you might get TAS, toxic anterior segment syndrome.
I think that we need to also highlight the difference between the iodine that we normally use in theater, that is a 5%, and iodine that Rita was using in her study that is 0.6%. So there is a big difference, and this I'm trying to say. Probably we at the moment there is evidence in the clinic that the principle of povidone-iodine works in clinics at that percentage, 0.6%. We don't know in theater yet of the 0.6%. This I'm saying. We just this regarding I know that at the percentage of 5%, I agree with you. I will not put in the eye because can cause after theater, because could cause a TAS, as you say.
I think if we go back to the use of iodine in the clinic, the reason why resistance happens is because you have done your best guess for your antibiotic, and the bugs which you don't kill become resistant. If iodine is effective against all bugs, then you shouldn't get resistance because they should all be killed. Or polymicro in the ulcers, which are particularly complex or polymicrobial, that has a very big role to play, I think. So if you have a big ulcer, you could test it and then sterilize it and then get on with your appropriate antibiotics. One of the reasons we give intensive maybe every hour for 48 hours of antibiotic cover is because there's such a bacterial load. And being able to reduce that with iodine, it may, in the future, we may find out we need to repeat that to reduce the load, because the iodine will get used up as it does its work and needs to be replenished. But I think it's another weapon in our armamentarium to treat corneal infections. I'd be interested in Carlos's opinion. Does he think it has a role in herpetic eye disease?
Yes, as I told, nowadays we don't have, at least to my knowledge, any trial or any paper regarding the use of iodine, but it seems that it could work. So I totally agree with you. Sometimes I think to do a little study regarding this point, because I think it's very, very important. Many times we don't know which microbial keratitis we are fighting, actually, because the sample many times they are negative, or could be polymicrobial, etc. So I agree with you. I think this another weapon that we can use, but maybe it could be interesting.
I often think we get told that some herpetic viruses are resistant to encyclovir. Well, we don't know that whenever we start treating the patient.
Yeah.
And sometimes you use ganciclovir, but basically you use what is available. And I can't tell you if a virus is going to be resistant or not to the traditional treatment, but it might be useful in the resistant cases to acyclovir to use a virucidal like iodine.
True, because they have at least in vitro they have they work. It works. But
Vito.
Please, Rita.
Yes, may I ask to David, what about iodine and COVID-89? COVID.
So we did the report, the survey about the virucidal effect of iodine, and it was based on the fact that as we tried to restart surgery after the pandemic lockdown the first time round, people were very concerned that the surgeons were going to get COVID from the eyes of the patients. And we said, well, they're prepped and draped in a sterile manner. Let's look at the literature. And we deliberately looked at literature pre-pandemic, because there's a lot of opinion and politics and case reports and case series. And we found that povidone-iodine is extremely effective against all forms of virus, including coronavirus. And in the traditional 5% for 2 to 3 minutes in theatre, the whole ocular surface should be sterilized appropriately. So that should give us all reassurance. The question you actually are asking is, imagine that patient with COVID is in ICU and they have on their mucous membranes coronavirus. And in the ENT literature, they have been putting iodine up the nose and in the throat. And I wonder, for the patient in ICU, should they get some in their eyes as well to reduce the viral load? So it should reassure us, but the question comes, even if it's not licensed for use in coronavirus, is it a sensible thing to do? And I would suggest it's going to do more good than harm.
Okay.
Thank you very much. So I have another question from the chat box that raised, and then we close because we are nearly close to the end line of the meeting. So the question they're asking if we can use iodine in epithelial disease and stromal disease. My answer would be yes, we can use in both because the viral load will be in both. What do you think, Rita? What do you think, David and Carlos? And then we close.
The problem of the potential damage of iodine on the surface has been established from at least one study from an Italian group, Professor Aragona group, that tried iodine in medium to severe dry eye with the potential damage of ocular surface. In these cases, Professor Aragona didn't find any damage on the surface, and this I can say that it is related to two things. The first one is that the povidone-iodine in this case is very diluted, as I told you before, and the second that is a special solution with hyaluronic acid, vitamin E, and so on, and this can protect the environment of the ocular surface.
Thank you very much, Rita. David and Carlos, if you agree, we close here the webinar. And I want to thank you again for all your time, for preparing the talk, to give the talk, and for raising all these questions in the discussion and answer them. So thank you again, and I hope to see you in the next event. And
yes.
Thank you.
Thank you very much. Thank you for the invitation. Thank you.
Bye.
Thank you. Bye.
Bye.